Yeah.
All right, we are good to go.
Hi, everyone. I'm Dr. Diana Torres-Burgos, and we're going to allow just a minute or two more for people to enter, and then we'll get started briefly in 1 to 2 minutes. So it is now 7:03. I think we should get started since we have a wonderful full program tonight. So hi, everybody. Welcome to the National Hispanic Medical Association and National Medical Association joint webinar on the COVID-19 impact in the Black and Latino communities. Where are we now? As I mentioned, I'm Dr. Diana Torres-Burgos. I'm a pediatrician, preventive medicine, and public health physician. I have been with NHMA for many years, and I am currently the NHMA New York City chapter chair. We have a great program for you tonight with a lot of expert speakers, and hope that we broaden the conversation on the COVID impact in our communities. Before we begin, I'd like to introduce to you to Dr. Rachel Villanueva, who's my wonderful co-moderator, who will go over housekeeping, logistics, and CME. Dr. Villanueva? You need to unmute yourself.
That's the 4th time I've done that today. Great. I haven't been doing webinars just all year, but thank you, Dr. Torres-Burgos, and thank you everyone for joining us this evening. We're so excited for this webinar this evening. Dr. Burgos Torres and I have really been working on this since February. We thought we would do it then. And then it just happened that this time worked out best. And I think the conversation we're gonna have tonight will probably be a bit better than it would have been in February. So I'm very excited about our esteemed panelists and the conversation that I think our communities need to have. I'm also so excited that we have the opportunity to work together. I think that's probably one of the only good things out of COVID this year is that I've had the opportunity to work with a lot of different organizations that I might not have otherwise. I think a lot of times we work in silos for things that are mutual, things that are mutual subjects of interest for us. So this is, I hope, the beginning of just working a little bit closer together for our communities. So before we get started, I just want to go through some housekeeping, which you can see on the slide. The presentations will be followed by the Q&A. We'd ask that, as the presenters are speaking, that you type in any questions that you have into the Q&A and not into the chat. All microphones will be muted. It is being recorded. There'll be a post survey, and there is CME credit available should you want to have CME credit. And with that, I just wanted to go through just the 3 objectives for this evening, describing the impact of COVID and Latino and Black communities and current challenges they are facing, listing 3 ways that structural racism and the COVID-19 pandemic intersect, and describing 2 strategies to address vaccine access and confidence in the Black and Latino communities. And with that, I'll send it back to my lovely moderator, Dr. Torres-Burgos.
Thank you, Dr. Villanueva. I have a pleasure of presenting our first speaker, Dr. Oxiris Barbot. She is a pediatrician, a public health expert, and innovative leader for health equity. She's currently a senior fellow for public health and social justice at the JPB Foundation, and also adjunct associate professor at Columbia University Mailman School of Public Health. She was formerly the health commissioner of the New York City Department of Health and was very instrumental in directing the city's first wave response of the COVID pandemic, in addition to addressing the racial inequities. I am very privileged and excited to introduce you now to Dr. Oxiris Barbot. Dr. Barbot?
Thank you, Dr. Torres-Burgos. It's a pleasure to be here with you all tonight. And I have the distinct honor and pressure of being the first speaker. And so we've got a tight agenda, and I'm going to jump right into. So my job is to answer the question, where are we now? And the short answer to that is that as compared to the first wave, Black and Brown people are still disproportionately impacted by COVID-19. I'm going to share a few statistics on cases, deaths, vaccinations, to ground us in the now, and then share a few thoughts about how we can influence the dynamics, accounting for inequities even more intentionally moving forward. So this first slide reminds you of what you already know, but it gives me an opportunity to share that as of earlier this week, over 32 million people have been infected in this country over the course of the pandemic. And that as of, again, earlier this week, 572,200 souls have been lost because of COVID-19. The daily case numbers remain similar to those seen at the peak of the second wave last summer, which is about 50,000 to 65,000 new cases per day. And in spite of these numbers, I think the trajectory that we're seeing gives us cautious optimism that the numbers are going in the right direction. But there's lots of wild cards in the scenario still. So for example, more states are lifting restrictions, and what will that mean with somewhat stagnating immunization numbers? What's the ongoing transmission of variants going to do to the overall trajectory of the pandemic? And then many parts of the world, unfortunately, are still on fire with COVID. So while there is optimism based on what we're seeing with our transmission curves, I think we all need to be cautiously optimistic. The other thing that this slide reminds us about are that there are huge caveats about the completeness of race and ethnicity data in these data that I'm going to be presenting. In addition, we have the caveats of issues related to access to testing and access to medical care. But in spite of all of those, these are the numbers that we have and how the pandemic has transpired over this last year. And so as compared to the first part of the pandemic, what we're seeing currently is many more young people are being infected, and we don't yet know very much about the long-term morbidity of COVID-19. I think an important bright note is that mortality rates per 100,000 are significantly down for all racial and ethnic groups. And so that's very positive. There are two things that are not on this slide that I want to talk about that help to sort of set this stage further for the conversation that we're going to have for the rest of this evening. One is we don't typically talk enough about elderly Black and Brown Americans. And so one of the things that I wanted to highlight is a study that was done and published through the Kaiser Family Foundation looking at mortality rates in nursing homes and comparing nursing homes that have higher percentages of Black and Latino residents as compared to white residents. And in the analysis, looking at those that had 20% more African American as being high Black nursing homes, or having more than 20% Latinos as having high Latino residents. And the point of highlighting this is that nationwide, nursing homes that had higher Black populations reported 23% more mortality, and high Latino nursing homes reported 11% more mortality as compared to white nursing homes, let's call them. And even though Blacks and Latinos represent 12% and 6% of nursing home population, so they're reporting mortality at twice the rate that they account for in these nursing homes. So that's an area of ongoing concern. The other thing I wanted to just highlight in here is that of children. So children of color are more likely to get COVID, and when they do get COVID, they are more likely to account for children that die because of COVID. In fact, there have, of the deaths in children related to COVID, 62% of them have been due to Black and Latino children. They're also more likely to get the rare and extreme immune system response that's linked to COVID, MISC, or the multi-system inflammatory syndrome in children. And so of the over 2,000 kids that have been diagnosed with MISC, at least 69% of the cases have occurred in Black and Latino children. Last thing I want to highlight, or the last thing I want to highlight for kids, is that a recent study published by the American Academy of Pediatrics, and it's a statistical analysis that looks at mortality across the US, projects that about 40,000 young people have lost a parent to COVID. And that translates into 1 out of every 13 deaths means that a child under the age of 18 has lost a parent. And this is likely an undercount because it doesn't include the deaths of grandparents who may be primary caretakers. And so while this analysis didn't report on Latino children, what it showed is that Black children disproportionately affected with 20% of parental loss, while representing 14% of the child population. The last thing I'll say with regards to children is that Child Trends, a nonpartisan research organization, recently looked at a survey and found that 29% of Latino children and 31% of Black households with children are experiencing 3 or more health and economic difficulties at the same time. These include unemployment, difficulty paying expenses, not being caught up on rent or mortgage payments, as well as food insufficiency, lack of health insurance, and poor physical or mental health. And so these outcomes now and in the first wave of COVID are driven by risk factors that have nothing to do with biology and everything to do with the everyday reality of countless Black and Brown people in this country, and that I'm sure that Dr. Jones will talk about more in her presentation. But I want to just give an overview of those risk factors, which is being overrepresented in essential services jobs, including food prep, delivery, meat packing, transit workers, home health aides, and frontline positions in the healthcare industry, as well as having a higher likelihood of not having paid sick leave, not being able to work from home, living in overcrowded and or multi-generational households, having little to no access to generational wealth transfer to help weather this catastrophe, and especially for Latinos, lower rates of health insurance and concern about public charge. And so let me pivot now in the next slide to one of the principal ways forward and out of this disaster, and that is vaccinations. And so as of earlier this week, and actually as of the 27th, 28.9% of the adult population is fully vaccinated. 67.7% of people over 65 are fully vaccinated. But what this slide shows are things that I find very concerning and that hopefully we can get more into in the Q&A. One is that more than a year into this pandemic, and CDC still doesn't have a good way to get race and ethnicity data. It's a sad statement on our whole system, and it's unacceptable. So here you see that race and ethnicity data is available for 58% of those that are fully immunized and 55% for those that are partially immunized, as compared to 91% had gender data and 92% had age data. So it's not clear to me why we still have these issues. That being said, we see here the breakdown for those that are fully vaccinated. And the point here is that Blacks and Latinos are still not being vaccinated at the percent of the population which we represent. And so what that translates into is that Latinos fully vaccinated represent 9.8% in spite of being 17.2% of the US population. Blacks fully vaccinated at 8.4% in spite of being 12.4% of the population, and whites being fully vaccinated at 67.6% in spite of representing 61.2% of the population. The next slide reminds us that there's been a lot of talk about mistrust in the medical establishment in both of our communities, which is real, but it shouldn't crowd out the immediate and most pressing issue of vaccine access. And so what this really shows is that in both groups, the percentage of people getting vaccinated or wanting to be vaccinated as soon as possible is going up quickly. That's great news. The folks who are waiting, who have been taking a wait and see attitude, is rapidly decreasing. And that's also very good news. And then the groups that are in the no way, no how, no way in hell am I getting vaccinated, that is staying steady and slowly declining. And so that reminds us that we need to focus on what we call the movable middle. 8 out of 10 Latinos and Blacks report relying on their doctor's advice for vaccination, which really speaks strongly to the notion of trusted relationships. Other thing that makes a huge difference is knowing someone who's been vaccinated. And that next slide, you'll see that what it shows us in the gray bars is that overall, 20% of adults know no one who's been vaccinated, and that this jumps to 36% for Latinos and 29% for Blacks. And so what I want to just sort of end with is this notion that I actually wrote about in Modern Healthcare back in March, which seems like a lifetime ago, which was only last month. And that's the notion that when we lead with equity, everybody wins. We all know from our quality improvement work that what gets measured gets managed. And if we don't have accurate data on race and ethnicity, then we won't be able to take the most efficient route to fully protecting our communities, including through vaccinations. While the Biden administration has done many things to start addressing racial inequities in health, they haven't done one of the most basic, which is setting equity expectations, especially for the number of people that have been vaccinated. And so in order for these approaches to be maximally effective, they have to be partnered with structural changes that only the federal government can do and that can be measured and managed now and over time. And so imagine what our immunization stats would look like if the federal government based replenishment of vaccine supply on the percentage of previous doses for which race and ethnicity is known. Beyond that, what if the federal government set performance expectations that states vaccinate their Black and Latino residents commensurate to the percentage of the population they represent in their state? And what if they incentivize states that meet or exceed those thresholds by giving them additional vaccines above what they would have gotten in the next delivery as recognition of their efforts to meet the needs of communities most ravaged by COVID, with the expectation that the additional precious doses would be distributed to everyone in the state, irrespective of their race. And so this approach reinforces the notion that achieving health equity requires urgency and necessitates hardwiring it into our workflows. It shouldn't be inevitable that Black and Latinos keep getting pushed back to the back of the vaccination line because of the inertia of structural racism. By placing performance expectations that are not punitive, we reinforce the notion that when we lead with equity, everybody wins. And my hope is that during the Q&A, folks will ask questions about new things that have been recently announced, such as the removal of recommendations about wearing masks in public, about rapid at-home testing, and a whole host of other things that I think hold promise for changing the trajectory of this pandemic. And with that, I want to turn it back over to Dr. Torres-Burgos, sorry.
I'm muted. I think I'm going to be muted for the whole program because it seems to be my MO today. Thank you so much, Dr. Barbot. So much to digest and a lot of food for thought. I think especially the need for equity metrics and the lack of race and ethnicity data and how that affects our ability to move forward in the pandemic and measure those equity metrics. And so what you said, I think, leads us perfectly into our next speaker, that when we lead with equity, everybody wins. And so I have the great honor to present Dr. Camara Jones, who's a family physician and epidemiologist. Really, the 3 lines that I'm going to say about her does nowhere near the justice for any of our speakers today. We try to limit our introductions. She focuses on the impacts of racism on health and the well-being of the nation. She's the past president of the APHA and a current presidential visiting scholar at the Yale School of Medicine. Dr. Jones.
Thank you, Dr. Villanueva. And Dr. Barbot, that was an amazing presentation. So much for me to just sort of put a little icing on, I would say. Great. So I'd like to share my own screen. And I fashioned my 10 minutes of remarks as structural racism and the other pandemic. I'm waiting for my thing. Okay. So, you know, we've heard about the dual pandemics. Structural racism, of course, is the foundational one that we have. And then, of course, COVID-19. I wanted to start out, at first I wasn't going to tell any of my stories because I only have 10 minutes, but I wanted to give this one of my allegories on issues of race and racism, one of my teaching stories based on my own real life experience to you all, our listeners, as a tool, not to teach you something you don't know, but as a communication tool when you start talking to other people about racism and they feel like, oh, well, racism doesn't exist. So the moral of this story, Dual Reality, a restaurant saga, is that yes, racism exists, even if your own life experience has screamed that this is the land of equal opportunity. The story is based on my experience. One Saturday as a first-year medical student, I had awakened early, as was my wont, and started studying, even though it was a Saturday. It was about mid-afternoon. Some friends came over. Did they distract me from my studies? Oh, no. Oh no, we all got to studying long and hard. And then as it got late, we got hungry and I had no food in the apartment, which was so typical of me that my friends said, okay, Camara, never mind, but we are hungry. Let's go into town and find something to eat. So we do. We set off into town and we find a restaurant and we walk in and we sit down. Menus are presented. We order our food. Food is served. Here we are eating. So perhaps not the story about racism existing in a restaurant that you thought I was going to tell. But hold on. As I sat there with my friends eating, I looked across the room and I noticed a sign that was a startling revelation to me about racism. So now maybe I've intrigued you and you're wondering, well, Dr. Jones, what did the sign say? Oh, well, what did the sign say? The sign said open. So now maybe I've lost some of you. So let me recap. Here we are sitting in this restaurant. I'm sitting in the restaurant eating with my friends. I look across the room, I see a sign that says open, thinking no more about it. I would assume that other hungry people could come in, sit down, order their food and eat. But because I knew something about the two-sided nature of those signs, I recognized that now indeed the restaurant was closed due to the hour, but firmly closed. And that other hungry people, just a few feet away from me, but on the other side of that sign, would not be able to come in and sit down and order their food and eat. And that's when I understood that racism structures open, closed signs in our society. That racism structures, if you will, a dual reality. And for those who are sitting inside the restaurant at the table of opportunity eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on because it is difficult for any of us to recognize a system of inequity that privileges us. So, for example, it's difficult for men to recognize male privilege and sexism. It's difficult for white Americans to recognize white privilege and racism. In fact, it's difficult for all Americans to recognize our American privilege in the global context, although we are living that right now with our kind of relative glut of vaccines relative to other countries around the world. But those on the outside now are very well aware that there's a two-sided sign going on because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know if you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. It doesn't even compel you to act, but it does equip you to act so that if you care about those on the other side of the sign, which is an if, you could even talk to the restaurant owner, who is, after all, inside with you. And you could say, restaurant owner, there are hungry people outside. Why don't you open the door, let them come in? You'll make more money. And oh, the conversations we could have. Or maybe what you'll do sitting inside that restaurant, maybe you'll try to pass some food through the window. Or maybe you'll try to tear down the sign or break through the door. But at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat. Because you'll understand something about the two-sided nature of that sign. So when I just have 4 or 5 minutes to talk to a group and let members of that group who may not understand that racism exists, get a visceral feeling for that, this is the story I tell. And it's not just that racism structures two-sided or multi-sided signs and creates a dual or multifaceted reality. I have actually started a 3-hour conversation with the following question. How could people who are born inside the restaurant know something about the two-sided nature of that sign? And of course, there are many ways to know, right? That's why it was a 3-hour conversation. I often tell people that I am heartened that more people who are born inside the restaurant have gotten a sense of the two-sided nature of the sign. More people who just a year ago might have been sitting inside the restaurant saying, well, what are those people saying? Black lives matter, brown lives matter. Don't they know all lives matter? Are now affirming Black lives matter, brown lives matter. More of those people are putting together the words structural racism, systemic racism. This is important. It's heartening because we have to name racism if we're going to address racism. But naming racism, although it is essential, it's necessary, it is insufficient. And I am actually a little bit nervous about all of the different groups that have put out statements or, you know, changed their website with a banner, or even some of the 183 declarations that racism is a public health crisis that have been made in 33 states across the nation. If we just say a thing, as important as that is, we may forget in 6 months why we said that thing, because racism denial is so staunchly held in this nation and so seductive that we may fall back into what I describe as the somnolence, the sleepiness of racism denial, which means we have to go beyond naming racism and move to action. We need to be tearing down the sign. And of course, racism is not just a sign, it's the sign, it's the door, it's the lock, it's a whole system going on. We have to dismantle the lock, take the door off the hinges, because if we start acting, we will not forget why we are acting. So I am very quickly, I could talk into this next slide for 10 minutes, but I'm just going to share with you my definition of racism, which is that racism is a system. So it's not an individual character flaw, not a personal moral failing, not a psychiatric illness, as some people have suggested, although it can manifest in all of those ways. But in its essence, racism is a system of power, a system of doing what? Racism is a system of structuring opportunity and of assigning value based on the social interpretation of how one looks, which is what we call race. We know that race is not biology, that unfairly disadvantages some individuals and communities, but every unfair disadvantage has its reciprocal unfair advantage. So it also unfairly advantages other individuals and communities. But the third impact that many of us miss is that racism is sapping the strength of the whole society through the waste of human resources. Maybe in the Q&A, we can talk a little bit more about each of those elements of my definition. I also want to just very quickly introduce to you that we need to launch actually a national campaign against racism, as I did 5 years ago when I was president of the American Public Health Association. And there were 3 tasks. To name racism is number 1. The second is to ask, how is racism operating here, to identify levers for intervention, to identify targets for action. And that's a legitimate question, because racism is a system with identifiable and addressable mechanisms in our structures, policies, practices, norms, and values, which are different elements of decision-making, actually. Structures are actually the who, what, when, and where of decision-making, especially who's at the table and who's not, and what's on the agenda and what's not. And if structures are the who, what, when, and where of decision-making, policies are the written how of decision-making, practices and norms are the unwritten how of decision-making, sometimes harder to pin down, actually, and values are the why. So I wanted to quickly apply that question, how is racism operating here, to the disproportionate infection and death rates of people of color to COVID-19. And so let me just say the basic what's happening with regard to excess deaths of people of color from COVID-19 is that we are more likely to become infected because we're more exposed and less protected. And then once infected, we're more likely to die because we're more burdened by chronic diseases with less access to healthcare. None of that, as Dr. Barbot said, is in our biology. And also the fact that we're more exposed and less protected or more burdened by chronic diseases with less access to healthcare did not just so happen, right? It is because of racism. So how is racism operating here, looking at structures, policies, practices, norms, and values? Well, in terms of structures, racial and ethnic segregation coupled with disinvestment. Segregation is not bad, but when you have segregation coupled with disinvestment, first of all, has led to us being more exposed. We're in these frontline jobs because of schools usually in poor neighborhoods, poorly funded schools, poor educational outcomes many times, another generation lost. The only jobs you have are these frontline, essential, but not valued, really disposable jobs. So we're more exposed in the frontline jobs. And also when some of our young people might go out to be, they don't have the, sick leave or any of it, and then they come back into more crowded housing, more intergenerational housing. But the same residential segregation with disinvestment also is why we're more burdened by chronic diseases, limited food options leading to obesity and diabetes and the like, poison environments and lung disease and kidney disease and all of that. So it doesn't just so happen. Well, what about policies? Well, limited personal protective equipment for low-wage essential workers, which is still the case in terms of meatpacking plants or warehouses or grocery or driving around. Now we're thinking about our protection more as the vaccine, but because we're not even getting the vaccine in our right numbers. So the personal protective equipment includes all of that whole range. So that means that we're less protected. In terms of the practices of first placing testing centers and then vaccination sites in affluent areas or way out, in a stadium, nobody can get there and the like, results in less access to healthcare. Of course, we can talk about many more examples in all of these. In terms of norms, racism denial, that staunch racism denial, which is the position of many people in our nation for centuries, has resulted in what I think of as victim blaming. When we talk about vaccine hesitancy, yeah, there were a lot of people around this country that were vaccine hesitant. The first survey I saw showed that, for example, Black folks, 35% were saying, well, I'm going to wait and see, but 42% of rural people and 42% of Republicans, even in that early survey, were saying that, but nobody focused on that. Yes, Black and brown people, we have legitimate rights to be a little vaccine hesitant, but people have been acting like that's the reason that we aren't getting the vaccine proportionate with our infection rates or death rates, much less proportionate with our population numbers, right? When really, as Dr. Barbot said, the issue is access and structural access. And if you are sending it through pharmacies, what about pharmacy deserts and the like? And then finally, the values. White supremacist ideology, this hierarchy of human valuation by race with white folks at the top, actually has led in many, many things to inaction in the face of need, indifference, and even normalization of these differences that we're seeing, where people of color are more likely to be infected, more likely to be hospitalized, and more likely to die. That's not even news anymore. That's been normalized, just like our infant mortality rate differences have been normalized, or maternal mortality rate differences, or diabetes or obesity. All of these other differences have been normalized. So I just want to close with a very interesting, this is the edge of my work now. I actually talk about 7 different barriers to achieving health equity and how they undergird racism denial, how they are the values targets for anti-racism action, how these are the social and cultural barriers to achieving health equity. I'm going to focus on only number 1, and then in discussion we can talk about others, but the narrow focus on the individual in our nation makes systems and structures either invisible or seemingly irrelevant. That has a lot to do with racism denial, but it also has to do with how we have been dealing in this COVID pandemic with issue after issue. I mean, at first I noticed it with regard to testing, and then with regard to masking, and then with regard to the discussions around school reopening, and then with regard to the vaccine trial endpoints, and then with regard to vaccine optimism in general, and then with regard to vaccine rollout phasing, and finally with regard to how we're talking about COVID-19 and the death toll. So I just want to quickly talk to you about how the narrow focus on the individual that characterizes our nation not only undergirds the denial of racism and denial and narrow sense of self-interest and all of that, but it has hampered our efforts at the COVID-19 pandemic. So testing in 2020, the US treated COVID-19 as a medical care issue rather than a public health issue. We're still doing that to a great extent. But what that meant is a medical care approach to testing meant that we were trying to confirm individual diagnoses one by one for those who were either symptomatic or exposed, where a public health approach would be estimating the amount of virus that's circulating in the population by testing both symptomatic and asymptomatic persons, doing population-based surveys, probability surveys where you just take some people, or even testing the wastewater. Why does this matter? It matters because if we're basing our estimates on how much virus is circulating in the population based on positive tests or hospitalizations or deaths, there's a time delay and an undercount in estimates of the amount of virus. And especially when we were experiencing exponential spread between November, December to January, if you are 7 to 10 days late because you're looking at positive test results in symptomatic people, that's 2 generations of spread. Your estimate of how much virus there is, it's like you have a 7 to 10 day old Polaroid picture. Your estimate is 4 times off. If you're looking at hospitalizations, there's a 2 to 3 week delay, deaths 3 to 5 weeks delay, whereas probability surveys, which we still have not done, that's real time and allows us to have real time action. In terms of masking, individual orientation is that we wear masks primarily to protect oneself. Collective orientation, you wear masks primarily to protect others. Why does this matter? I think we still need mask mandates. I think they're essential to protect the health of the public in the face of individual objections. And even when the CDC new recommendations, which were hard for people to, the lay public to understand, I don't know. I would rather go with mask mandates right now because we don't know, even if as we get more and more people in the US vaccinated, this is a world pandemic. With regard to school reopening discussions, the individual focus was saying, well, the kids don't seem to be getting that sick. Community focus was the possibility that children can spread disease. And even though the CDC has said that children don't seem to be spreading disease, the B117 variant in the UK was found because they noticed that the children were now spreading disease into the population. And that variant is becoming more predominant in the US. So we need safeguards against spread from schools into communities, whatever those safeguards are going to be. But we can't just say, oh, that's solved. In terms of vaccine trial endpoints, individual focus was let's let the endpoint be symptomatic disease. But a population focus would say, well, let's swab the nose every week of the people in our clinical trials to identify asymptomatic viral spread too. Why does it matter? Because asymptomatic spread is fueling the pandemic. We now have more data outside of the clinical trials that the vaccine seems to also be stopping asymptomatic spread. But at the beginning, we didn't know. Vaccine optimism. Well, we know that the virus will infect any available vulnerable host. Two things, available and vulnerable. The focus on vaccines is to decrease the vulnerability of individual hosts, but the public health strategies are to decrease the number of available hosts by hiding us behind masks or at home and all of that. And we need to continue to fully implement public health strategies, both at the individual and governmental levels, even as we roll out our highly anticipated vaccines. In terms of the rollout phases, we need to acknowledge two types of risk. Individual risk is increased vulnerability due to age or medical conditions. Structural risk is increased exposure at work or where we live. And why does it matter? Vaccine allocation that addresses structural risk is needed to address the disproportionate impact of COVID-19 on communities of color. I could go deep here, but I know that my time is really gone. So the last thing I want to say is, with regard to the COVID-19 death toll, individual focus says that those dying from COVID-19 represent private losses to loved ones. The collective focus says that those dying from COVID-19 represent shared losses to the whole society. Racism and COVID-19 are sapping the strength of the whole society. Why does it matter? We need to recognize and mourn our monumental collective loss as a nation, 572,000 and counting. And that goes even for those who have not yet experienced the loss of a family member, friend, colleague, or patient to COVID-19. So thank you for letting me just throw out some of these ideas, and I turn it back over probably to either Dr. Villanueva or Dr. Torres-Burgos, but thank you very much.
Thank you so much, Dr. Jones. That was just amazing and really thoughtful and very, I think these are the kind of conversations we need to have. The idea of speaking about racism, not on the individual, but on the structural level. And it was just really amazing. And I thank you very, very much for that presentation. And moving along, I am honored to present Dr. Elena Rios. She is the founding member of NHMA, the National Hispanic Medical Association. She's the president and CEO and represents the interests of Latino physicians and health professionals. She's also the president of the National Hispanic Foundation, which provides educational research activities on Latino health to improve the health of Latinos. She has won multiple awards I couldn't even tell you all, and recognitions for her great leadership, advocacy, and legislative work. She also serves on multiple boards, all in the mission to improve the health of Latinos in the United States. I have worked with Dr. Rios for many years, and I'm very honored to introduce her to speak to you on what NHMA is doing in regards to the COVID-19 pandemic in our communities. Dr. Rios?
Yeah, thank you, Diana. I think that, can you hear me?
Yes.
Okay. I'm going to go ahead and skip some of the first slides because we've already gone over all the different problems that we have. Let me just say, go ahead and keep going. I think for the Latino population, we have a lot of challenges, and and there's a lot of opportunities. These are some of the disparities. Keep going. The next slide, let me just stop there. The Biden administration has done a great job in looking at some of the social determinants that we need to really focus on to be able to decrease the disparities in our communities and to allow more people to have a little bit more quality of life right now, given COVID-19. And the American Rescue Plan is probably one of the most transformational policies since the Affordable Care Act, actually, for health. It includes food and a lot more food supports from the agricultural nutrition programs, including SNAP or food stamps. Schools and institutions of higher education are going to get funding, child care and programs for older Americans. Of course, the COVID-19 vaccinations, testing, treatment, and prevention. More mental health and substance use disorders, as we've seen more anxiety in our communities, and especially with children staying home and parents having to deal with a lot of, living check to check and being unemployed. A lot more mental health and substance use disorders. A lot of funding, especially for our emergency rental assistance, homeowner assistance, small businesses, states, territories, our tribes, and also programs for healthcare workers, transportation workers, as was mentioned, all the essential workers. And believe it or not, we've seen a new revival of research with community-based efforts, and we're having healthcare providers in rural areas. Next slide. In addition, there's a whole new focus on trying to decrease poverty, and by giving tax credits, not only for families, but for their children. And for Latinos with big families, that's very, very important. And I think the other thing that's important is the focus on insurance, having more premium assistance for insurance and to have more insurance coverage through Medicaid. And of course, for all our uninsured and our undocumented, there's a lot more funding for clinics, et cetera. Next slide. Some of the, I think the most important positive announcement, and Oxiris said it great, I think, is that the hesitancy for COVID vaccines is really down in our communities. And this was from December when the vaccines first started, that 7 in 10 Hispanic adults said that they would get the COVID vaccine. Next slide. So what are we seeing about, what are we doing about how we can help our communities? One thing that hasn't been mentioned is we need a health workforce that looks like us. The NHMA has a College Health Scholars Program. I'm not going to go through all this, but the purpose is really to develop mentoring for students that are interested in going into medicine, dentistry, nursing, public health, and graduate science. We have partners in California and Texas. We have seen an outcome with a significant increase in science and math grades, also an interest in the career. And I have to say that our program will end next year, but we have over 600 students right now that are being mentored, and we have over 2,000 students that have actually been recruited to our conferences in California, Texas, and the East Coast. Next slide. The other thing that we're doing is trying to sustain our programs and to identify funding and visibility by publications so that we can continue to develop our mentoring, which is very important to the Hispanic Medical Association. Next slide. The other thing we're doing is bringing back our leadership program, and we've been funded by CDC to develop training of doctors about public health. We definitely need more leaders in public health, and we're actively recruiting for our first class. We've got funded for the next 5 years. Next slide. And our other opportunities, of course, are our relationships with our government affairs activities with the White House and HHS. And just to let everybody know that the Intergovernmental Affairs Office of the Office of the Secretary Becerra has been a great connection to hospitals and clinics and all the medical associations that are involved, including the NMA. We're also involved with the CDC, the Office of Minority Health, NIH, FDA, and the new HHS Community Corps, which is a volunteer effort. We were called to get doctors to go to the border, for example, to help with the immigrants and in the detention centers. Next slide. And also, I just had to mention that these are some of the most important things happening at NIH, the SEAL program, the Community Engagement Alliance. NHMA does have some faculty. Olvin Carrasquillo is one of them from the University of Miami. They are creating not only research based on community efforts to understand strategies for our communities about COVID-19 uptake with vaccinations, et cetera, but also looking at specific states and building statewide coalitions. And these are other URLs and websites to look at the federal government activities in different agencies. And next slide. Lastly, I was just going to comment on the importance of vaccination, and it was mentioned by Camara Jones very well that the vaccination effort has been really focused on individuals, and we decided that we needed to focus on families. So the NHMA campaign is called Vaccinate for All, or Vacunas para Todos. And let me just say that we are supported by CDC, Johnson & Johnson, and Bio. It consists of two major efforts. One is individual training through these monthly webinars and social media in our fellows program, but also organizational training. We are having monthly meetings for sharing of information between our Hispanic Health Professional Leadership Network, the Hispanic doctors, nurses, pharmacists, social workers, health executives, the Latino Caucus of Public Health, the behavioral groups, as well as our own conferences, newsletters, website that all of our organizations have. We are building information that will be culturally relevant with one of our community PR firms called Culture One World, and we will be developing a resource hub to put everything together. And next slide. This is just, again, I think important to know that we are asking everyone to sign up and be a champion, either an individual or an organization. We are doing media training, and we are placing doctors and nurses, et cetera, to work with not only Latino media, Spanish media, but also our magazines and the National Association of Broadcasters and the Ad Council. And we have a lot of other campaigns going on in the Latino community that we are going to link to through our hub. And then last slide, I think, is just our connection. This is our NHMAMD.org website where you can sign up for our Vaccinate for All. We encourage all of you to sign up, be a member, and support NHMA. Thank you very much.
Okay, there I am. I couldn't find myself, sorry. Thank you so much for all of that rich information, Dr. Rios, and to see all of the work that's being done to educate the community and also to highlight the things that need to get done as we move forward. And so if anyone has any questions for Dr. Rios, if you could put them in the Q&A. And then I have the honor once again of another great honor for me to introduce Dr. Oliver Brooks. He is the immediate past president of the National Medical Association, our 120th president, and the chief medical officer of Watts Healthcare Corporation in Los Angeles. Last June, he was asked to be part of the advisory committee on immunization practices of the or the ACIP, the COVID-19 working group, discussing and making recommendations to the ACIP regarding potential COVID-19 vaccine prioritization. So with that, I will not waste any more time and have introduce Dr. Brooks. Thank you, Dr. Brooks.
All right, thank you very much, President-elect Dr. Villanueva. Also, thank you, Dr. Torres-Burgos, for your information. And, Dr. Barbot, speaking on COVID-19 rates and the coverage, Dr. Jones, elegantly, as always, on structural racism, and it's real, and she breaks it down. And underrepresented minorities, that was very important from Dr. Rios, because we will improve the health of African Americans and Latinos when we have more of us presenting as providers in our community. So I My video is shared and open. So no relevant disclosures. Next slide. So I'm going to skip a lot of my slides because a lot of it has already been covered, and it will allow us to have more robust discussion in the Q&A. So I'm looking at vaccine hesitancy. So there's been some discussion on this. This is a graphic that shows the large majority of people that accept all vaccines. Then there's a continuum of those that accept, some delay, some refuse some, and not all. And then there are those that refuse all, and those in the middle refuse are unsure. So the focus when you're trying to get people vaccinated is on the continuum in the middle. Those on the right side are not going to get vaccinated. The more you say, the less likely. Those on the left are already getting it done. So that's where the focus is. Next slide. So let's look at this a little more closely. This was a model that was developed about how you would approach vaccine hesitancy. So it's the 3 C's model, broken down into 3, Venn diagram concentric circles: complacency, confidence, and convenience. So looking at confidence, this seems to be the one most in play with the COVID-19 vaccine. So vaccine confidence is defined as trust in the effectiveness and safety of the vaccine. That is clearly making people hesitant. The system that delivers the vaccine, the government, healthcare, pharmaceutical, that seems to be a concern. And the motivation of policymakers who decide on it, that seems to be a major concern. Those 3 areas are where I would say 90% of the hesitancy lies. Vaccine complacency. The perceived risk of the disease is low and the vaccine isn't deemed necessary. I think most people seem to understand, at least in the Black and Latino community, that that is not the case, that the perceived disease is vaccine preventable, is of high risk. And vaccine convenience, this is another one that almost dovetails into what Dr. Jones was saying. Physical availability, affordability, willingness to pay. So we don't have that, but geographic accessibility, ability to understand the need and appeal of immunization services. So right there, those that are the lower socioeconomic status have less vaccine convenience. It's not easy. You can't get off from work. You don't get sick leave. You have to take 2 buses, no transportation. So this is looking objectively at where hesitancy may be placed. Next slide. So this was covered by Dr. Barbot, but I just want to show that over time, this from December to March, going from bottom to top, the far right, you got anywhere from 20 to 23% that are either only if required, they'll get vaccinated, or definitely not. So again, that's that hardcore. No matter what you do, you're not going to affect them. The other areas already vaccinated as soon as they can get it, they're waiting and seeing. Those areas, as was stated, are diminishing. So again, with hesitancy, the focus is going to be on the 2 blue bars in the middle, those who need to get as soon as possible, and those are waiting and seeing. The ones on the far right, they're not going to get vaccinated. Next slide. So she spoke to this, but this demonstrates the same information. Those that are getting vaccinated are going up, those that are waiting to get vaccinated are going down, and it's pretty stagnant or stable for those that are in those last 2, will not, or only if forced to. Next slide. So next slide. So this was a small study of it was an N of 24 of African Americans in a focus group in terms of why they were looking at not getting vaccinated, their reasons or drivers of hesitancy. And even though it was a small focus group number, it is what I've been hearing, is what I've been getting anecdotally, and we're involved in a project here at Watts Healthcare Corporation. And so it parallels what I'm hearing. Percentage of vaccine process development has been rushed. It has these unethical historical practices. We've all heard that, concerns about safety and efficacy, and mistrust in the government. However, importantly, what can we do to get people vaccinated? Dr. Rios showed good information on what can be done. Having a track record, so over time, more people getting vaccinated, and a recommendation from a trusted provider. The data shows that people trust healthcare providers to give them information regarding their health, including vaccines. Next slide. Next slide. All right, so again, recommendations. What contributes to vaccine hesitancy in the Black community, and how can it be addressed? So the recommendations, the slide before that was the issue. Public health messages and communication strategies to to address vaccine hesitancy should be tailored through authentic community engagement over the short term, critical increase the trustworthiness of healthcare organizations, pharmaceutical companies, the government over the long term. So we need more trust in the long term. Vaccine messaging should acknowledge systemic racism. Thank you, Dr. Jones. As a justifiable reason. Whenever I speak to people that are Black, I say, I get it. Yeah, it's there. That shouldn't stop you from getting vaccinated, but it is real. And we have to address healthcare providers. We got to convince the vaccinators that they need to get vaccinated. There was the amount of hesitancy in healthcare providers that were Black and Latino were about paralleling the overall Black and Latino community as a whole. So we need more healthcare providers to get buy-in. Next slide. And this was some data, I mean, it's really small, you can't see it, but this was kind of presented by Dr. Barbot. It just shows you what's happening state by state. And basically the far right column, that is the light blue, is the percent in the population. For this one is for, this is Blacks. And then the other three columns, the percent of people that are vaccinated, the number of cases and the percent of deaths. So you would want the percent of vaccination on the right in green to be at or above the bars on the far right, the light blue. And then the percent of cases. So basically what this is showing is we are not getting vaccinated at the same rate we are in the population. The number of cases, number of deaths are higher than we are in the population. This is state by state. She showed it nationwide. Next slide. And this is the same thing for the Latinx population. So if you just choose Texas as a state. So Latinx are 40X%, I can't even read that, but they're only 31% of those that are being vaccinated, but 50% of the cases and 40+% of the deaths. So a large state like Texas, more Latinx people dying, getting it, less people getting vaccinated. So that leads to more cases and more death. Next slide. And so this is one person who had almost no hesitancy, and that is me. I actually was a little concerned about the messenger RNA platform, but I was more concerned about getting COVID. So thank you very much, and we can now roll into whatever time we have left for questions.
Thank you so much, Dr. Brooks. That was very great presentation, letting us know about vaccine hesitancy in our communities. And what I'd like to do is open it up to the Q&A and panel discussion, and we will continue that until everybody's able, and hopefully for the next 15-20 minutes. And we got a number of questions from our audience, and want to start out with one, which is the need for race and ethnicity data is very vital so that we know we can leverage it for the resources. How do we push for that? How do we actually get that 54% to 100%?
So I'm happy to start, and then I'm sure others will contribute. I think, one of the things that I was trying to emphasize is this is our opportunity to put urgency behind needing race and ethnicity data, and by predicating additional vaccine replenishment on providing race and ethnicity data, I can't think of a more sort of deliberate approach to putting the pressure where the decision making is being made, right? So put myself in a situation of a governor, and CDC is saying, you're not going to get any more vaccines because you're not giving us race and ethnicity data. You can bet that the next phone call I'm going to make is going to be to the president of the biggest healthcare delivery system in that state and rip that person a new one, right? And then I'm going to go down the line for all of the health systems. And so I think we need to have those kind of approaches to press the issue that I think it may have been Dr. Jones that said it, or one of the other speakers, like we have to stop blaming the victim, stop perpetuating narratives that, blame it on some historical something or reason or other of why it is that supposedly our communities don't want to get vaccinated, and put the emphasis where it really is in terms of vaccination. And I think, and then I'll get off my soapbox. The other thing is all of the things that we are doing as a community are incredibly important. And when I say as a community, meaning Black and Latino doctors, Black and Latino CBOs, all of that is incredibly important. But you know what? It's the same old, same old. And until we put people who are in decision-making positions on the hotspot about why are you not creating the expectation from the top, then we're always going to have these situations where federal government is going to throw money at communities, say, here, do community engagement, here, do this, here, do that. And whatever the results are that we get, it's on you. I think we need to change that dynamic.
I was so impressed, Dr. Barbot, about I hadn't read your paper from March, but how could we move those ideas to action? Because I think that all of the strategies that you described are exactly what we need to do. And especially when you said that 90% of gender was reported and all. So we have to figure out what is the barrier. I mean, it's a reluctance or whatever, but maybe people don't want to ask race, but honestly, the most racism works on this socially assigned race anyway. So they should just have the people just mark off whatever race they think it is. That's better. That's the race that racism operates on anyway. It doesn't operate on self-identified race ethnicity. Is that social assignment without asking, excuse me, how do you self-identify? Or excuse me, where were you born? Where were your parents born? Or may I have some blood? Right, I have a genetic hypothesis. So if perhaps if we said to people, you don't have to ask the race because they're checking the gender off without asking. And so maybe is that the barrier? And say, just check off the race that you see. That is actually the more accurate race in terms of the substrate racism operates on. If we said that and then said, or else you're not going to get this money. I mean, I don't know. Is that?
So my suggestion would be that the president of, or I would say the president-elect of NMA and the president of NHMA have a joint letter to the new CDC director. I take her at her word that she's incredibly dedicated to health equity, and say, explain to us how it is that you can have data for over 90% on gender and age, but yet race and ethnicity are still stagnating at 55 and 58%. And how can we work together to help you implement systems? I think Rachel said it very well earlier, like we need to work on systems so that this is no longer an issue.
I think a lot of the problem is in healthcare, in all public, private.
Yeah,
race and ethnicity is still optional, and it's self-reported, and it's just ridiculous for our communities not to have required data collection that will help us change policies.
Thank you. We have one question here, and it's open to the panel. What effective strategies to bring in clinicians who are Black and Brown on board to being promoters of getting vaccines in our communities, and the issue of how do you address, lack of confidence in what information our communities are receiving?
I'll stab at that. One thing,
go ahead, Dr. Brooks.
Be straight up and address the fact that I get it. That will give you the listener some confidence that you're just not ignoring it, that you're not thinking about they are just being hysterical or unscientific. The other thing is understand that vaccine hesitancy is a psychological response. It is not a scientific response. So do not try to give them facts and figures and data and information. Go to where their heart, it's in the heart and not the brain. And I think what we need to do, we have to, the same way you try to sell people soap, you need to have clear messaging. It needs to be on the radio, it needs to be social media, television as indicated, and people need to be speaking more or less with a clear message. The vaccine is safe and effective. Again, different reasons for different people. But I really strongly believe that, because there's a nurse that has some of that, the way this nurse can say is, I got vaccinated, the vaccine is safe and effective. Tell me why you don't want to. And have an answer for them. But again, be focused on where they're coming from and not what you think they think.
I also think that for the NHMA with our campaign Vaccinate for All, we are trying and we are working with different communities. We have chapters in different places, and I know NMA does too. And I'd be happy to try to, develop the collaboration at the local level where we have doctors that are giving vaccines in the, health fair type situations or in their hospitals and in their clinics. But maybe we just push forward with getting more of our doctors to get involved, especially, and I know the residents are also really interested in helping out and medical students. And I know the whole community core that's being developed is all about getting more people to volunteer in our communities. So I think there is a way we can help deliver more positive messages, role modeling with vaccinations and getting more people vaccinated. And especially as the younger people now are able to get vaccinated, it's really important that as they go back to school, go back to high school, go back to college, that they also tell their families about the importance of getting vaccinated.
Great, thank you. One other question from our audience is, can you talk about the difficulty of wanting to eliminate medical racism? And that is treating Black and Latino patients differently while still recognizing, treating patients on their individual cases and not race and ethnicity. And how do we deal with that? And what are strategies that we can promote within our communities? And that's
I'll
open to
start.
them.
Yeah, well, I'll start just by observing. So the NMA has a long history of addressing these kinds of issues, but and probably NHMA as well. But the American Medical Association in November passed 3 very important policy statements in their House of Delegates. The first was to say that racism was a public health crisis. The second is to say that race is not biology. And the third was to say we have to stop this racial adjustment in, GFR, glomerular filtration rate, or in our lung function tests and all. So they have 3 different policy statements now. So now the thing is to move toward enacting those in our individual health systems and the like. But the AMA, as conservative as it is, passed those 3 policies. And so you may be aware that Dr. Michelle Morse and Bram Wispelwey wrote an article maybe 3 weeks ago now, where they were talking about how to address even the, this is a little of a off thing, but how to address the fact that in Boston, Black patients who were admitted to Mass General Brigham with heart problems were sent to the general medical floor, but white patients were sent to the cardiology service, or the CCU. And so they had so when you talk about these issues and you point out the thing, and then you have a strategy, they got so much pushback. So that's the thing. We have to be ready for the pushback. We have to not be shy about the strategies. We've been documenting these problems for a long time. Now we have to say, okay, well, we might need some race conscious work going on here, because the status quo is not getting us anywhere. Inaction in the face of need is a major way that structural racism continues to produce the same results that it has produced for decades and centuries. So we need to act. And when we propose action, we get pushback, but we just have to be strong.
Comments? Next question. Do you think the disclosure of race and ethnicity is not there because of fear to disclose this because of the distrust of the system? And what strategies besides self-disclosure can we use? Would anyone want to take that?
Well, I think Oxiris mentioned incentives. Oxiris, do you want to echo what you mentioned? I think it was very important to have incentives for funding to states, for example, or to counties. The public health infrastructure really needs to be the place to get the incentives I think.
So I think that there are 2 levels for incentives. One is, as I mentioned, in terms of creating expectations that states will vaccinate commensurate to population distribution, and then giving additional vaccines as a reward, for lack of a better term. I think the other thing, however, is, and I just saw this yesterday, the state of West Virginia is offering everybody between the age of 16 and 25 $100 savings bond if they get vaccinated. And so, like, let's think through a scenario where, you know, if you don't give people $100 savings bond, maybe you give them $100 worth of food. I can guarantee you a lot more people are going to get vaccinated, right? And so when we talk about combining healthcare and addressing the social determinants of health, I can't think of a better way to spend $100 than to give somebody $100 worth of food to get them vaccinated and have it be done at their neighborhood pharmacy. And so, you know, that's just sort of one of the most recent ideas. I think, honestly, maybe we survey community all over the country and tell us, what would it take to get you vaccinated? Let's reframe it to not only address the hesitancy as Dr. Brooks so eloquently laid out, but what would it take to make you feel good about sitting in that chair and getting that shot?
Thank you.
May I
Next-
just say one more thing? So
Sure.
that's true. And why are we having to bribe people in the United States to get vaccinated when we have hoarded so much of the vaccine anyway? And there's so many other countries, many African nations thinking their first vaccine that's going to get to them is going to be in 2022. Like, you know, so this is sort of like a rich nation's problem, but it is affecting us differentially within this rich nation. So so all of that is true. And I want to just put a plug for the US needs to stop standing in the way of an intellectual property waiver that India and South Africa and many other nations have now asked the World Trade Organization for, so that other nations that don't have the recipe for the vaccines but have the production capability can start producing the vaccine. Because even when we do get 80%, 90% of our population vaccinated, we are not going to be safe, because this is a global pandemic. And the more the virus spreads, the more it's going to mutate, and our vaccines soon will be weak to nothing, right? And unless we close our borders rock solid, which is a bad idea, then as long as the pandemic is raging anywhere, we are vulnerable. So I just want to say, we need to think about us within this country. But we have sort of a wealth. We've sucked up a lot of the vaccine, and we're standing in the way of other people getting it.
So I couldn't agree more with Dr. Jones. And, you know, my comments are within the context of a more equitable distribution of vaccination worldwide. The other thing I will say is I do have concerns as we move from vaccinating folks sort of from the emergency lens to one of, for lack of a better term, convenience. What I'm starting to hear is that, for example, businesses are requiring vaccination for young people to have summer jobs. And so if we don't have equitable access for our communities, then what is the ripple effect in terms of reifying structural racism and the barriers that they have to getting summer jobs? What will be the barriers to our communities being able to go back to their regular jobs as adults? And so all of these things, I think, need to have greater consideration as implications for our communities not getting vaccinated.
Thank you. I think we're going to have time for maybe one or two more questions. I appreciate that. Dr. Brooks, this question is for you. What has been NMA's efforts to improve vaccine confidence in Black communities, and what community partners are essential for this success?
So our House of Delegates mandated that the present President, Dr. Leon McDougall, form a COVID-19 task force. And importantly, it wasn't just for the vaccine, it's for testing, therapeutics, and vaccination. So we did that. I am a member. Dr. Villanueva, President-elect Dr. Villanueva is a member also. We met with Pfizer, Moderna, J&J. We got the information from the horse's mouth. We asked them all the hard questions. Does it affect infertility, about sickle cell patients, immunosuppressed, Blacks in their specific issues, if any? And when we found out that there were no issues, that we felt all our answers were appropriately answered, questions were appropriately answered. We released a statement saying that we support vaccination in the African American, well, period. And it was coming from the NMA, so that would endorse it in the African American community. Since then, we have met with J&J, and we have stated that we are on board with whatever the determinations are being made. What we're doing is on the local level, we have 6 regions. We have each state has an association, and then local, like 6 in California. All of those groups are having meetings and discussing, promoting, and advocating for vaccinating. And we have a relationship. Well, we have our relationship with Dr. Rios, who was my partner when I was president, and she's been just doing a phenomenal job with NHMA, National Hispanic Medical Association. So that's where we are right now with that.
Great, that's great information. I think I know we're going up on time, so I'll leave this as one of our last questions. Can you respond to how we track vaccinations among the undocumented community, still protecting them in their legal status, and the fear that exists in that community? It's open to the panel.
Let me just say one thing, that I think that our country does admit that it's taken care of in the vaccination, so it's free for everyone, and also that there is no requirement for any, there's very much a privacy activity going on, no requirement to send the information to any kind of government agency like the INS, et cetera. But I do think that our country needs to look at the essential workers perhaps as a way to have a program for those essential workers who may be undocumented or may have green cards and not citizenship yet, without talking about immigration reform as a total program, but perhaps a focused effort on the essential workers that now seems to be our mainstream society has recognized that COVID-19 and the vaccinations are needed for essential workers as a group. And the other thing I would say is the farm worker, and meat packing plants and places like that where you do see undocumented working, that there are worker programs for undocumented to come into this country and actually work. Well, and they pay sales taxes, they pay taxes, with tax ID numbers, maybe not Social Security, but tax ID numbers. And I think that there has to be a way to be able to provide healthcare services with more funding from the federal government and increase the dish and the charity care to doctors and clinics that we have had and that we need to continue to build. But those are just some ideas. But
Great. Thank you so much, Dr. Rios. So I apologize for all those questions we just do not have a chance to get to, but I'd like to, before we close the evening, just get one thought from each of our panelists to close out. Dr. Brooks?
It's something that would pivot with what Dr. Jones has presented, Camara Jones. Isabel Wilkerson said in her book, Caste, the reason why we don't have universal care is because we have an individual focus in this country. And if other countries that see it as a community, as a total population, it'd be a different approach. And then the other thing, what I realized when I was president of NMA last year, when we get to health equity, we get to full equity. Right now, you can have, equal income, equal transportation, equal jobs. You still have disproportionate outcomes. Health equity equals full equity.
Thank you. Dr. Rios?
Oh, let me just say ditto to Dr. Brooks. We need health care for all. And our campaign, I'll just say once again, we did not want to be individual focused. We said vaccinate for all. Vacunas para todos. And please join us and NMA and all of our partners here today in continuing the education of all of our communities to please get vaccinated for COVID-19.
Great, thank you. Dr. Barbot?
So I want to add my ditto to Dr. Brooks's statement. And I also want to emphasize what I said earlier and what I like to use as my tagline, which is when we lead with equity, everybody wins, right? And that there are ways of incentivizing equity metrics that allow all of us to achieve equity. And so, yeah, I'll leave it at that.
Thank you so much. And Dr. Jones?
So ditto, ditto, ditto. And I'm really happy that the NHMA and NMA are working together in this, because collective action empowers us, it protects us, it inspires us, So that's the first thing. And then I just want to leave with 3 principles for achieving health equity, because that's what we're getting at. Valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. So you value everybody equally, but when you come to the resources, that's where the equity, where you have to use need as the metric of how we distribute our resources.
Fantastic. Thank you very much. And to my wonderful co-moderator, Dr. Rachel Villanueva.
Thank you. I just wanted to say thank you so much to our panelists. I wish we could have a half-day symposium or a full-day symposium on this, and maybe that is going to be our next ask of you. But I'm really, as Dr. Jones says, I'm just really encouraged by our 2 organizations working together. There's so much power in our collaboration, and as I become president in July, it will be my goal for us to, continue to forge a better relationship together. And so hopefully this will be maybe just the first of our collaborative webinars together, because I think our communities, it's clear our communities need our collective efforts. And so I just wanted to say thank you. And then I particularly want to just say thank you to the NHMA staff who helped to put this webinar together, and who, herding cats, herding doctors to get things to be put in on time is terrible. And Vincent Garrity, I really want to thank him so very much for all of his help, and to my co-moderator as well for keeping me to task. So thank you.
And I want to thank everybody for taking the time to stay on a little longer. I want to thank all our amazing speakers, wonderful co-moderator, our staff. This was a pleasure. We were very excited, and we hope to continue this conversation. And with that, I want to bid you all a great night. As you see, we will continue doing some COVID-19 virtual briefings. You see the next one online. But again, I hope to in the future also be able to collaborate so we can face these challenges that both our communities face. One other thing, you will be getting emails if you've registered, and it will give you directions on how you can obtain CME. So please look forward to that. The slides and recordings will be available in about a week's time. So for those who wanted to have that, they will. And again, I want to wish everybody a very good night, and thank you to everyone. And we need to move forward and somehow fix it. All right. Have a good night, everyone.
Bye. Thank you.
All right, thank you all.
Thank you all.
Bye. Vito, you still there?
Yes, I am.
Okay.
Good job, Diana.
It's still
Oh,
live.
it was good to meet you.
It's still live, you guys. It's still live on Facebook.
Okay. Are we still live? Vito, are we off? No. Okay. Well, to everyone, a good night. I will send emails to everyone. I appreciate it. And it was wonderful seeing you, Camara.
Oh,
Great
lovely.
to see you.
Yes,
Thank you so
thank
much. Have a good
Thank you.
night, everyone. Thank you, Dr. Brooks.
All right, thank you and good night.
Good night.